Hey, good evening, everyone. Tony Gonzalez here, and another edition of bringing the community together to share valuable information. You know, COVID-19 is on everybody's mind, and there's a lot other things going on, as well as allergies and a lot of other medical kind of conditions that people have questions on. You know, and we're fortunate today that Dr. Diaz is going to be kind of giving a breakdown. Dr. Diaz is a medical director from Allergy San Antonio, and he's going to give a breakdown on kind of just some basic things, symptoms that folks might see, and he's going to do a deep dive into that. You know, I want to encourage everyone. We want this to be as interactive as possible. So if you have any questions, by all means, shoot questions out there. We want it to be informative and educational to everybody. So without further ado, you know, turn it over to Dr. Diaz.
Thank you, Tony. Appreciate you being here and doing the intro tonight, and everything that you're doing for our community. You're working hard. I appreciate that. And to everyone who's participating, I want to say welcome and thanks for joining us. This idea came up after we were inundated in our practice with a number of patients who had asthma calling us and asking questions specific to their asthma. And I thought it was an opportunity to bring information to the community, and I appreciate everyone who has shared this, including the Allergy and Asthma Network. I do appreciate the opportunity to kind of share this information. It is, as Tony said, very casual, and it's going to be open for questions. So please send in your questions, and hopefully we'll be able to get to all the questions. And again, it's going to be not so scientific. It's not going to be into the weeds, into the details, into the pathophysiology or the microbiology of the disease. It's going to be hopefully information for our patients with asthma. And I just want to just quickly point out that on the nomenclature, I don't know if we're switching to the slides yet, but I want to talk about the nomenclature of COVID, because that's an interesting question. People ask, why is it called COVID? As you can see here, it's very simple. CO stands for coronavirus. The VI stands for virus. D is the disease, and the year was 2019 when it was first reported. Initially, when we started this idea, we were going to talk mainly for the local area in Bexar County, and I think it is very important to point out that we're in the very early stages. We're in the very early stages, and I think things that we're doing and things that the mayor has implemented, and especially social distancing, will have an impact, and we need to work very hard to continue to do that. And I know it's very difficult, but in Bexar County, you can see we have 229 deaths as of a few hours ago. And the important note on this slide is that we have 66 community acquired. So it's definitely in the community. Patients are getting the infection with no known risk factors, such as travel to areas where COVID is endemic or direct contact with someone who has been exposed to COVID-19. So we're early in Bexar County, but we definitely anticipate continued and increased cases. And unfortunately, we have had 9 deaths, and I'm sure that is very tragic for not just the families, but for all of us here in Bexar County. I know everyone's keeping up with this data. I'm impressed when I watch the news. This is all I hear. I hear it constantly. The numbers are always changing, but just to give you an idea of where we are, I remember sitting in my living room a couple of weeks ago looking at the U.S. data and seeing just a few thousand people, and now we're well over 200,000 people with the infection here in the United States. And most experts still feel that it's still very early. So the question came up as to why are we doing this? And again, I have a lot of patients who have called and asked questions. I get people stopping me and asking me questions, and I know my colleagues, as I've talked to my colleagues, are having the same questions come up. If you think of the number of patients who have asthma, we have an 8 to 10% of patients in general have asthma. That's 30 million asthmatics in this country. In Bexar County, again, the area where we initially focused, there's over 100,000 patients with asthma. And the important thing to note is that, although the numbers may be low, is that 5 to 10% of these patients have severe asthma. And that's the population that we're most concerned with as physicians that take care of patients with asthma. It's the severe asthmatics, and 5 to 10% of patients who have asthma have severe asthma. And importantly, and I want to point this out, is that a lot of the data suggests that over 50% of patients who have asthma are not well controlled. And the main reason they're not well controlled is because they're not taking their basic medications, their controller therapies. And one of those controller therapies is inhaled steroids. And that's kind of raised some controversy in what people are talking about. Should I be on steroids? Should I take steroids or not? And we're going to address those. I know this is a complicated slide, but I just want to point out these are kind of the questions that I've gotten. If I have asthma, am I at higher risk for contracting the infection? If I have asthma, am I at higher risk for having complications from my asthma? And we'll talk about those in detail. How do I tell the difference between a COVID infection and an asthma exacerbation? Do I take my inhaled steroids? What about nebulizers? There's a lot of information that's being distributed about the safety and use of nebulizers and the droplet particles and the chance of dispersing more particles into the air. And then the last two questions is, what should I do if I have an asthma exacerbation and I treat it? How do I treat that asthma exacerbation? And then lastly, I'm going to talk very briefly on some of the things that we're doing. So this is simple. Am I at higher risk? Are asthmatics in general at higher risk for contracting the illness? There was a couple of studies that have been published, and there's a couple of there's some information that's come out of China. When you look at patients who have been hospitalized for COVID-19, there did not appear to be an increased percentage of them having asthma when you compare it to the general population. So the simple answer to this is that if you have asthma, you're not really at increased risk of developing the infection. Now, we'll talk about, are you at increased risk of having complications? But the important thing is that in general, it's not believed that if you have asthma, you're at increased risk of contracting the illness. Am I at higher risk for having complications? Am I at higher risk if I get COVID-19 infection and I have asthma? Am I at higher risk? And this is very interesting. The CDC has put asthma in the category of higher risk populations for having complications should they get COVID-19 infection. But I want to point out why. COVID-19 is a respiratory illness. It affects mainly the respiratory tract. It's transmitted via the respiratory tract. It's a coronavirus, and other coronaviruses, which I'm sure you all have heard of, MERS and SARS, other coronaviruses have been proven to increase asthma exacerbations if you get those infections. Most experts that I've talked to, and again, the CDC has put it on their website as far as high risk for having complications. In general, most experts feel that if you have asthma, you are clearly at higher risk for having an asthma exacerbation if you get the COVID infection. But there's really no data to confirm this. But again, it's on the CDC list of risk factors for having more severe disease and complications. And the data right now doesn't show that, but again, we are treating that as a high risk for complications if you have asthma and get COVID. A question that I often get is how do I tell the difference? And this is a simple slide, and you can see that some of the symptoms that I've mentioned that you see on the left there are present in both of these conditions. The most common symptom that people have if you have COVID-19 infection, when you look at the data, is fever. So you can see, that's why I put that on top. Is this asthma or is this a COVID infection? If you have fever, in general, it's less likely to be asthma. Now, you can have an asthma attack from the flu or another illness that may cause fever, but in general, you don't see fever with asthma exacerbations, and you very commonly see it in COVID-19 infections. And body aches, as you can see there, in general, COVID-19 is a flu-like illness like influenza and will cause typical flu-like symptoms of fever, chills, night sweats, body aches. But in general, you don't see body aches in patients who have an asthma exacerbation versus a COVID infection. Cough. You probably have heard that cough is very common in COVID. Many patients develop cough even before they develop shortness of breath. And it is also a very common symptom in asthma. So cough is not a good differentiator. But if you have asthma and you have a history of asthma, you know what your asthma feels like. You know what the cough is like, wet or dry, and you have an idea if it's an asthma exacerbation, although it's not totally clear. Cough can be present in both conditions. Shortness of breath can also be present in both conditions. There were some interesting reports that came out, many of y'all may have heard, and there was some data that came out of China also that says GI manifestations, only GI manifestations can be a symptom of COVID-19 without even having respiratory symptoms. So it's important to note that if you have GI symptoms and you have some fever and you have some cough, it's probably less likely to be an asthma exacerbation and more likely to be a COVID-19 or another infection. And then finally, we're in the oak season right now. We're in the middle of spring season. A lot of our asthmatics have worsened asthma symptoms during the spring due to the pollination. And today, especially in San Antonio, it was clear, it was a little bit windy, it was perfect temperature for that pollination to continue and occur and worsen. So you normally don't see allergy symptoms in a COVID-19 infection, but you relatively commonly see allergy symptoms in someone who is having an asthma exacerbation, especially if they're allergic. I did put in wheezing. It's a little controversial, but I can tell you that in general, the COVID-19 infection is more associated with shortness of breath. You don't often see that much wheezing. Of course, in the more severe patients, you can see that. So I think it's very important to point out the differentiating factors, especially to our asthmatics. And I hope this table is useful, and obviously it'll be available after this presentation. One of the big things that we heard early on was the use of steroids. Do I use steroids? And if you look at the bottom of this slide, there is data out there about steroids and influenza and steroids and other coronaviruses. And if you give systemic steroids, oral steroids, injectable steroids to patients who have a viral infection, there is a lot of information and data that does say it increases viral shedding, suggesting that it could worsen the viral infection. And so based on that information is why we're being very reluctant to use prednisone and oral steroids or injectable steroids in patients at this time because of that concern. But if you look at the top of this slide, inhaled steroids clearly do not fall in this category. I mentioned in the earlier slide that over 50% of our patients with asthma have uncontrolled asthma. That means that they're having ongoing airway inflammation. That means that if they get a COVID-19 or an influenza infection, it may worsen those asthma symptoms. We are making a strong recommendation to all of our patients with asthma that they continue taking their inhaled steroids and their controller medications. We're being careful in patients who have an asthma attack and trying to decipher, do we use steroids or not? And that's really a case-by-case basis. I have used steroids in some patients with asthma this week already after working that exercise and trying to figure out what's causing that asthma exacerbation. And if I believe that there's no risk of COVID and there is no COVID-19 infection, then I quickly go into the mode of I'm going to treat this like a regular asthma exacerbation. So very important that anybody with asthma take their controller medications, especially during this time, and do not stop even if they're inhaled steroids. The other controversy now is about the use of nebulizers. And we prescribed a nebulizer for a young child with asthma today, and we had a discussion. Should we be giving him a nebulizer and trying to use a meter dose inhaler with a spacer? There is data that shows that nebulizers disperse droplets in the air that can last for several hours. And if you're infected with COVID-19, there's strong evidence that it could be more transmitted with those droplets that are floating in the air, and those droplets can stay in the air for several hours. So based on that information, in general, in COVID-19 infections, the use of nebulizers is really discouraged. The question is, if you have asthma and you use your nebulizer, or even COPD and you use a nebulizer, what do you do? So in general, we're recommending that if you have asthma, an exacerbation, and your meter dose inhalers don't provide relief, that you go to your nebulizer. If you feel you need to use your nebulizer, you go to your nebulizer. Now, we are recommending that you use the nebulizer in areas where there's not going to be a concentration of those droplets. In fact, we're telling people if they have an extension cord, do the nebulizer on your patio. Do it outside if you can to decrease that low risk anyway, but to decrease the possibility of transmitting infected droplets in the air. So again, we recommend that if you use a nebulizer, you don't use it if you're COVID-19 infected, of course. And there are many, the vast majority of patients who are getting this COVID-19 infection are staying home. And so the question comes up, do they use their nebulizer at home? And we're strongly recommending that if you're using a nebulizer, that you use it kind of self-quarantine in a different room, but even preferably in an area where there's going to be a less chance of those particles becoming concentrated and causing potential infection. So I'm about to wrap it up. I only have a couple more slides, and we'll take some questions. I see that we're getting several questions coming in. But so what do I do now? What should I do now if I'm a patient or a caretaker or a parent of a child with asthma? There was some data that came out of the CDC today that reviewed and discussed scientifically pre-symptomatic transmission of COVID. And it's been on the news ever since then, because I heard it on the way in. There's no question that a significant percentage of patients who are getting COVID-19 are getting it from patients who are asymptomatic before or pre-symptomatic before they got their symptoms. That is why social distancing is still probably the most important thing that we can do. I was driving to the office this morning. We've taken some precautions, which I'll tell you about, but I was kind of surprised at how busy the highways were this morning. And I couldn't really believe that everyone was on the road for essential needed trips out of their house. So the most important thing we can do, and I can't overemphasize, is decrease the risk. I was talking to my mentor, Dr. Lockie, in South Florida this morning, and he said, this is a kind of an opinion, but he said that everyone should be wearing masks, regardless, like what they do in China. And apparently the Wall Street Journal had an article this morning about that. But clearly, the reason for wearing a mask is to prevent you infecting someone else more so than prevent you from getting the infection. So decrease the risk, and that's why I put that first. You see social distancing and steroids. I mentioned steroids in there again, mainly because of the concern. If you have an asthma exacerbation, talk to your provider. You must continue taking all of your controller medications. Uncontrolled asthma may have worse outcomes. If you have an exacerbation, can predispose you to having an exacerbation. People with uncontrolled asthma have a much higher chance of having asthma attacks. And the confusion now, is it COVID, is it asthma? Even more so is the reason why you should be taking and continuing your controller therapies. You must control your asthma. I mentioned that stopping medications will increase your risk. Everyone should have an action plan, especially children. It doesn't have to be complex. It's usually a written plan. For the schools, we have a little more details, but everyone should know exactly what they should be doing should they have asthma symptoms. And so I strongly encourage that everyone have a written plan of what they're going to do, especially for their children. An issue has come up as far as how much medicine do I stock up on. Most of the guidelines say a 30-day, maybe a 60-day supply of medications. And I want to emphasize, when I talk about medications, I'm talking about your asthma therapy, your controller therapy, your rescue therapy, but don't forget about your allergy therapy, because there's abundance of data that confirms that patients who have allergic asthma and their allergy symptoms, their allergic rhinitis acts up, they get sinusitis, it can clearly worsen their asthma exacerbation or cause an asthma exacerbation. So I encourage everyone, when you're stocking up, be sure and stock up on all your medicines, including your allergy medicines. I'm not sure if going to the doctor right now or to a clinic to get a flu shot is really considered essential, but if you have a chance, be up to date on your flu, and if you're asthmatic, follow the guidelines on being updated with your pneumonia vaccine. It is flu season also. And the guidelines are still suggesting that if someone comes in with a suspected COVID infection, that you swab them for the flu first before you swab them for COVID. No question that flu vaccination is important and decreases the incidence of flu and decreases your chances of having the flu. So I strongly recommend that if you're in your doctor's office and you have not received a flu vaccination, that you do. And of course, if you have significant problems, reach out to your primary care provider or your asthma specialist if you have questions. And then I'll tell you what we're doing in our clinic, and I think it's critical because we've had ongoing debates. What is an essential visit? What is not essential? So what we've done to really decrease the risk of transmission, we have converted almost all of our visits to telemedicine, which is phenomenal because 2 weeks ago we had never done telemedicine. Today we did 60 telemedicine visits with all of our providers in our clinic. And that's a steep learning curve. I saw an article that said that telemedicine increased by 350% in 1 week last week. So this is a new era. It may have changed what we're going to do moving forward. I prefer face-to-face visits. I prefer doing a physical examination, but a telemedicine visit can provide comfort, can provide some recommendations, and I think is a useful alternative if you can't come to the office. We are not recommending people come to the office for routine visits. We have 100% trying to avoid routine office visits that are not essential. But we are seeing patients, 2 or 3 a day, who are in the middle of an asthma exacerbation or have another medical condition that really needs to be evaluated. I had a new patient today, telemedicine visit, with a 90-year-old patient with asthma. A new patient visit, tried doing that telemedicine with a 90-year-old. No offense, but the technology is a little bit difficult. And I decided to bring her in. I know that she's 90 years old. I know that she shouldn't be going out, but I was concerned about her asthma symptoms. I want to make sure it's not cardiac and other things. So we actually scheduled her to come in, and we'll use the precautions that we use, that almost all clinics are using, monitoring temperatures, putting masks on people, patients, moving them to certain rooms if we suspect COVID, protecting our employees. One of the things that's come up a lot for us is, what about the use of biologics? For those of you all that may not know, I'm sure many of you do, biologics are therapies, they're monoclonal antibodies that are used to treat the more severe, maybe moderate to severe asthmatic that you have not been able to get controlled with typical medications and controller therapies. Well, since the majority of our patients who are on biologics for asthma have severe asthma, we've debated this and made the decision, and most experts in the allergy and asthma world and the American College of Allergy has recommended that biologics are essential. So realizing that and realizing these are severe asthmatics, we've made the decision to bring them in. They wait in their car. They call us, we call them when to come in, they get their shot, and they go back to their car. And we use social distancing, but we are continuing biologics for now. And I know that I've had that question asked a lot. We absolutely have stopped allergy injections, not essential. I have a lot of patients that are not real pleased with that. Allergy injections are often used to treat, obviously, allergic rhinitis and allergic asthma. We felt that there was too much traffic in the office and that there was too much risk for transmission, especially, as I mentioned earlier, that pre-symptomatic state of transmission. So we've decided that we're going to pick up the pieces on the other end when this is over and evaluate all of our allergy shot patients and make decisions on how we're going to restart them, because you just can't pick up and start giving shots again right after you've had a delay of 30 to 60 days from your allergy injections. So I hope that was a useful, I really enjoyed the opportunity to provide this information. What I'm going to do when my patients call me now and have questions, I'm going to send them to the YouTube of this event before I answer any of their questions. But I know that Tony's coming back up here, and I know that we've got some questions, and I don't know how long we're going to go, but why don't we take a handful of questions, and we will respond to these questions via email if we don't get to you on live today. Thank you again.
Thanks, Dr. Diaz. That was fantastic. I thought that was a very clear and concise rundown. And we've got folks from all over the country that are watching, so that's absolutely amazing. And we've got a ton of questions. The good news is you answered a lot of those in your presentation. I'm going through and I'm like, scratch that one off, scratch that one off, scratch that one off. But I do want to highlight a couple of them that kind of came up often. Talk a little bit about N95 masks again, right? So what I got out of it was more of a not necessarily preventive, but once you've already have COVID-19. Is that right? Or
so the use of masks is very important, obviously, whether it be a surgical mask or an N95. Mm-hmm. There's no question that a fitted N95 mask is better at protecting both the person wearing it and the person that he or she is coming exposed to.
Sure.
N95s are hard to get right now. Mm-hmm. They're a little more expensive than they were 6 weeks ago. Yeah. They're fitted, so they come in different sizes, so you need to be fitted, and the fitting part really should be accurate.
Okay.
So if a patient, so we don't have N95s in our office. We've tried to order some. I think I gave the word to order some more.
Yes.
So we're using surgical masks, and right. I got a count today that we're down to 350 masks in our office.
Yes.
And we're going through masks quickly.
Yeah.
So we recommend that obviously you wear a mask if you are at risk or have symptoms of COVID. When a patient walks into our clinic and they have a fever and a cough, we immediately put a mask on. We're using surgical masks, which are not as good as the N95.
Sure.
I think it's important. I mentioned earlier about this China experience and speaking with my mentor from South Florida and then I mentioned the pre-symptomatic transmission.
Yes.
I don't know if you've worn these masks very long, but, we try to wear them in the office, and it gets claustrophobic, and my glasses fog up.
Right.
But we need to make every effort to be wearing masks. And in my opinion, even if you're going out, the CDC has said that you can use these scarves and any kind. Yes. I had a patient come in today. He had a towel wrapped around. That's the patient that we swabbed. He had a towel wrapped around him, and we put a mask on him. But yes, the N95 is preferred over the surgical. And again, it's most important for the person who may have an infection or symptoms to wear it.
Yeah, no, that's perfect. Roxanne kind of asked that, hey, can you make a homemade mask? And Olga asked about N95 specifically. So thank you for that, for outlaying that. I want to dive into a little bit of a specific question. I thought this was Amanda Jones asked this question. My son was hospitalized in February with pneumonia without a swollen lymph node in his lungs. With all the symptoms of COVID-19, could he have had it back then?
So it's a little bit complicated because if he was hospitalized for pneumonia in February, depends on what kind of pneumonia, what the chest x-ray showed. Bacterial pneumonia often looks a little bit different than viral pneumonia on CAT scans and chest x-rays. So I don't know the details, but if he had symptoms of fever and coughing and chest congestion, body aches, and if he also had, quote, pneumonia, it would really depend on the picture, what you see on the chest x-rays and the CAT scans, and to rule out other causes of pneumonia with sputum cultures and things. But, I'm talking to a lot of people right now that are saying, about 6 weeks ago, I had flu-like symptoms and I got the flu vaccine, and I wonder, and I'm thinking like, yeah, maybe so. I'm looking forward to the post-crisis period where we start doing epidemiologic studies and start really looking at patients' antibody. What percentage of patients in a community or in an area are antibody positive, so we can really see how prevalent this infection was. Again, a large percentage of patients never have any symptoms at all.
Yes.
15 to 20% may never have any symptoms. Some may have just GI symptoms. So, Yes, it's a possibility, but again, it depends more on the chest X-ray and the CAT scan and the other symptoms and what was ruled out.
Okay.
Sorry if I'm long-winded. I'll cut it shorter.
No, that's good. That's good. No, it's been incredible the amount of interaction. Folks have really got on here, and if I heard you correct, we're going to try to continue to answer those questions even after this video is done. So by all means, keep sharing, keep liking it, get this information out. It's so critical. It's so critical to share this, to be educational. We're all looking for information. We all want to harden ourselves and prevent ourselves and loved ones from having to go down that route. So let me take another question from Eileen. At what point should a person with an immune compromised individual with asthma seek emergency treatment?
Yeah. So there's two things. If you have asthma or if you're immune compromised, we also have a lot of patients that we follow with immunodeficiencies. A critical population that really, in my opinion, should be nearly self-quarantined. Anybody with an immune deficiency, all the experts say, probably at higher risk for having complications, or surely at higher risk for having complications. And so the most important thing that you can do if you have an immune deficient state or a child with an immune deficiency is social distancing on steroids, I like to say. And I think that's the most important thing you do. But the question is when do I go get evaluated? If you're immune compromised and you're having infectious symptoms, I think you should call your provider. You should call your provider and talk through those symptoms. Before the crisis is the way I would manage it first. Mm-hmm. Now in the crisis, I would still suggest that you call your provider, talk through the symptoms, depends on the severity of the symptoms, what we think may be going on, and treat it. It's if you have more severe symptoms or you're advised by your provider to go get evaluation. If you have asthma, you mentioned asthma on that question. If you have asthma, when do you go see your doctor? I think you call if you're having increased asthma symptoms and you get advice in that regard. If you're having fever and chest tightness and cough and body aches and your asthma is worsening and acting up, you must call your provider and get directions on what to do. We really are trying, especially our patients with immune deficiencies and asthma, we're trying very hard to keep them out of the emergency room and out of the hospital areas where there's more risk of transmission. That's one of the reasons that we've stayed open for essential visits, to do our part in trying to keep people out of the emergency room. We're actually doing testing we're swabbing in our clinic, and so we're trying to do our part to keep people out of the emergency room.
Absolutely. All right. So another question from Vianne Hernandez: Should I start taking my rescue inhaler as a precaution?
Yeah. My recommendation would be no. You know, I guess I should have said at the very beginning of this is not supposed to be medical advice, right. Liability-wise. But my opinion is that you should continue on your controller therapies and use your controller therapies. If you have breakthrough symptoms, you should use your rescue therapy. If you're using your rescue therapy more than you should, if you're using your rescue therapy more than 2 or 3 times a week, or 3 or 4 times a week, you're having awakenings at night from sleep, your asthma is acting up, you use your rescue, but you contact your provider. And we're trying to prevent these uncontrolled or these asthma exacerbations from getting worse. But I would not recommend at this time using your rescue inhaler preventatively. Some people have suggested that if you use your rescue inhaler, your bronchodilators, you're opening up your airways. If you come in contact with the virus, you might get further and deeper deposition of that. So in general, no, we keep doing things the way we're doing them.
So let's get into resources, right? Milagros asks, where can I get tested and who can I call if I feel as if I have the symptoms for COVID-19?
So if you have the symptoms for COVID-19, if you think you do, if you're concerned or you're anxious about it, you need to call your provider, your doctor. If you have mild symptoms, probably best to stay home and treat it, the early part of the infection, the way you normally would. But what was the other part of that question? It was
Resources. Where do I go?
Yeah.
Where do I go?
Testing.
And
So
testing. Yes.
Testing
Where do I go for
is very controversial, really. We were fortunate enough to order a small quantity of the testing kits that were needed to do the swabs.
Yes.
We've been very, very selective in who we use them on. The CDC and even Bexar County, the Metro Health here in San Antonio, still have pretty strict guidelines. We're not opening it up for testing for just anybody that thinks they want to know or if they want to get checked. I mean, right now, because of the resources, we're still recommending that, if you have symptoms and you're a healthcare provider, yes, probably get tested. But if you have just mild symptoms and you don't have traveled to an area where COVID is endemic and you don't have a history of being in direct contact with a known COVID positive patient, you're going to more often than not get turned away.
Sure.
The patient I saw today in the clinic, he's usually not sick. He spends a lot of time outdoors. He came in, he was anxious, he was worried, he had a cough, he had a very low-grade fever, and he had a lot of back pain and muscle aches. So I did test him, but if you use the strict criteria, he probably wouldn't have been tested.
Perfect. So next question, this will be our last question, and then we'll wrap up, is from Brian, and it said, his question is, should I continue to take Advair if testing positive with COVID-19?
Ooh, that's a really good question. So if you take Advair for your asthma to control your asthma, and your asthma is well controlled, and you have COVID-19, realizing it's an inhaled steroid, and this is a very tough question to ask because of the details of this. If you were my patient and you were on Advair and you were COVID-19 positive, I might take you off the inhaled steroid for a very short while and use mainly rescue or other anti-inflammatories, but it really would depend on the level of your asthma control and the level of your asthma history. If you're COVID positive and you're on an inhaled steroid, you need to talk to your provider. Every case is going to be different.
Makes sense. Yeah. No. Thank you again, Dr. Diaz, for walking us through that, answering some very specific questions that were on a lot of people's mind. I will continue to ask you to share this video. Ask questions. The staff at Allergy San Antonio will get back to you on that. It is our goal to bring people together, bring information together with the experts to those that need it. And all of us, right, the saying is we're in it together. We are truly in it together in this time. So by all means, use this video as an informational, educational standpoint to do that. So thank you again, Dr. Diaz, for taking time out of your day. And we look forward to continuing the conversation.
Thank you, Tony, for continuing to do what you do.
Of course.
All right, good. That's a wrap. Check him out.